Access to safe, voluntary family planning is a human right. Family planning is central to gender equality and women's empowerment, and it is a key factor in reducing poverty. Yet many women in Kenya who want to avoid pregnancy are not using safe and effective family planning methods. It is a socio-economic conversation. UNFPA, the United Nations Population Fund, provides data which shows that family planning is one of the most cost-effective public health interventions and generates measurable positive change in the life of communities. In this special series, in partnership with FilmAid Kenya and UNFPA, we focus on family planning in Kenya.
Kwa majina naitwa Rosa Pula, niko na 20 years. Mimi ni single mother, naishi Kakuma 1 zone 2 block 2. Nimesikia family planning kuhusu. Kuna watu wakona watoto and then kuna wengine wanazaa kabla hata watoto wajafikia miaka 2 ama 3. So ndio maana watu wengine wanafaa waende kudumiwa mambo ya family planning. Ndio wasongeze miaka kama mwezi watoto wafikishe, ndio baadaye ndio watakuja kuzaa. Mimi nilijaribu ya 3 months ya shindano. Inanipeleka na nina attend something like 14 days. Nilikuwa na konda hiyo siku mbaya sana, ndio nikasema acha kwanza nitulie something like 2 months niende nijaribu ya 3 years. So ndio nikajaribu hiyo inaendana na damu zangu. Mimi kama Rose naweza mwambia mwenzangu enda hospitali madaktari wa kuwekea family planning ili pia ujichunge na mwanaume wako asikupe mimba na kabla bado mtoto ni mdogo. Pia ujichunge mtoto pia kifikisha miaka 2 ama 3 ya ndo kuja upate bengine kama unataka kuzaa mapema.
I am Man Usman Heli, 38 years of age, married and blessed with 3 kids, boys. The role I play in the community, I work as a community leader. This is what I used to tell community members. Instead for you to have a lot of children which you cannot manage, it is better you have 3, 2, whereby you can manage them, you can then send them to school, you can buy them something, you can buy them shoes, rather than having many children and you are not able to control them. I particularly do it in my own family, and it does not happen that way.
Hello, welcome to the One Health Lens podcast, where we have conversations around health and related topics, making it simple and easy for you to understand. I'm your host, Dr. Diana Wangari Gitao. We have been having a conversation around family planning in Kenya. And in this episode, we're talking about myths and misconceptions. We've had people who say that, number one, if I'm on a certain contraceptive method, I will not be able to have children in future. I mean, we've had people who have said, my husband left me because he discovered I was on family planning. And that's because he had a misconception around family planning. So today we have, as always, very important guests who are going to share with us around myths and misconceptions, how they encounter them, how they deal with them in their day-to-day work. So I will start with a lovely lady. Introduce yourself.
Thank you for having me, Dr. Diana. My name is Robina Anenemundi. I am the reproductive health coordinator at Nairobi, in Nairobi County, and I support reproductive health services from the county health office.
Karibu.
Asante.
Dr. Okech, introduce yourself.
Thank you very much. My name is Dr. Okech. I'm an obstetrician gynecologist and also serve as a technical director at Maristop. Yes.
Karibuni sana. I mean, I always find it that it's a tricky conversation to have, right?
Yeah.
Because it's a conversation around something that's very intimate, right? It's about planning your family. It's a conversation around how you engage in a relationship, whether it's marriage, whatever partnership you might have. It's a conversation about communities. There's a lot in there. There's a lot, right? And so maybe even we start from the beginning, and maybe I'll start with you, Dr. Okech. Maybe break down to us, because maybe most people will say family planning is just condoms, implants. Maybe give us an example or give us some categories of what family planning methods are.
All right. So thank you. So family planning is basically, we have a classification. We have a temporary and permanent method. And a permanent method, we have vasectomy in male and BTL, bilateral tubal ligation, or just tubal ligation. So these permanent methods are 99% effective. There's no method that is 100% effective. I think that's what we need to understand. Then on the other methods, the non-permanent methods, we have the long-acting reversible family planning. We have the short-acting. We have the barrier methods. We have hormonal methods, and the natural method. Yes.
Okay. So and also the key thing there, it's not just for females only, right? It's not just for females only. So Robina, I mean, you have worked in this sector for a while, right?
Yes.
And what I like about you is that, sitting from Nairobi City County, you interact with a dynamic range of people, population, right?
Yes.
So let's start of common myths that you hear, right? Misconceptions that you hear.
Yes. I'll present it from a perspective where I am a user.
Yes.
I am a service provider. So I have served communities, different communities, both urban and rural, with family planning, contraceptive methods. And so the young would want to present FP as contraception, and the women of reproductive age would want to refer to them as family planning methods.
Yes.
And so communities are diverse, and especially in our country, we have these many tribes, and each community holds their culture very close to their heart. And so as service providers, when we are serving these communities, we should be very aware of the communities that we are serving, so that again we are not bridging in on their culture. We are not stepping on their culture, because again that is what defines us. And so yes, there are some communities who believe that women are not independent enough to make decisions on their own. And so the family planning contraception conversation starts before the woman gets pregnant. These conversations should start there, so that as they are stepping into the family space, they are fully aware of the methods that they are going to take up.
Yeah.
For example, we have the hormonal and non-hormonal methods. Each comes with a wide range of effects.
Yes.
And so some of the myths that come along with some of the contraceptive methods is that I may not be able to deliver again if I take up, for example, one family planning method.
Yes.
And so that myth may not be true, because there's a side effect of delay to return to fertility.
Yes.
And so if you do not interact with a professional to actually break that up and help you understand that it is not that you will not deliver again, but you will delay to go back to the fertile state, then that again the community will capture it as not being able to deliver again. The other misconception, and it's especially around the IUD, the intrauterine contraceptive device,
Yes.
the copper T and hormonal.
Which is actually what I use.
Yeah, most people, there are stories in the community that maybe a baby was delivered holding it, or a baby was delivered having it patched on the face. And so again, it takes a professional to sit down with these community members and women to help them understand that this particular method is actually placed in the uterus where the baby normally survives for 9 months. Yes.
Absolutely. I mean, it's interesting because I like that you gave context, right? Because we must start off from first understanding the communities we deal with, right?
Yes.
Because there are some religious and cultural beliefs that they hold dear, right? And this informs how we'll interact with them, right?
Yes.
Because certainly I would imagine for communities that, as you rightfully said, that do not have women either as empowered or as independent in their decision making, even the fact them being able to procure or be able to access family planning methods is very different. It potentially starts with the man before even the woman, right? Which sort of explains why then you always need to have this conversation, as it's not a woman's only conversation, women's only, it's also males, right?
Yes.
And so, I mean, if you're to think about it, some of this come up then in a conversation, especially in service delivery, right? And I'll try bringing Dr. Okech, right? I imagine in your centers, you have people coming in who want a contraceptive method. And another thing I liked from Robina, depending on either generational gap, sometimes community gap, people refer to it as contraceptive, others will be family planning. And sometimes it's also part of that misconception is that it's only something that married people should talk about, right? Yet, if you're in a long-term committed relationship, right, it's a conversation you should have, right? So, but back to service delivery element, so people are coming into different centers, you must cancel them. Some of them you need to have these conversations. What do you hear, right? What do you hear?
So let me just an addition to some of the myths that I've heard.
Yes.
We have couples who've raised concerns that these methods will, like for IUCD, they'll migrate from the uterus to to the liver, to the heart.
Yes.
Some have said implant like Jadel can migrate from one arm to another. Which
it will jump across, or it will go through the blood system. Yes.
So part of counseling, we try and tell them these methods first are given by a qualified, a professional who has been trained. All right. So in terms of migration, did I migrate? What happens if it's done with someone who's not qualified? It can lead to perforation of the uterus. And that's not migration. It's just perforation of the uterus. Okay, that can happen if it's not done with that qualified personnel. Yes. So importantly, we take them through counseling. We give them all the other choices, right? The various family planning choices. It should be voluntary. We're not coercing them to have a particular method of family planning. And that's why it's important to train our healthcare providers on all methods of family planning so that we avoid things like provider bias, right? Like if you come to me and I'm good giving IUD, I don't know about other implants, I'll definitely give you IUD. I'm denying you chance to have other methods which will be effective to you. So counseling is very key. We provide you with evidence, adverse effects to these various family planning methods that you want to take. Then once you decide, we offer you, we give you the service.
I mean, I have even a list here of some of these myths and misconceptions. Only married people should use contraceptive. Only women need to use contraceptive, yet male barrier methods, condoms are examples of contraceptives. Women who use contraception are immoral or, they're promiscuous, right?
Yes.
Long-term use of contraception may lead to infertility, right? There's, of course, the religious influence, right? There's the fact that if you use some of the hormone-based contraceptives, aside from infertility, to lead to changes, cancer, and whatnot, right?
Libido loss.
Exactly.
We need to, first of all, understand why contraception or family planning.
Yes.
The basic reason as to why we encourage communities to take up family planning or contraception is they give themselves space and time to only have children when they need to, and so that they allow themselves time to be able to give this baby on board the best within their space.
Absolutely.
The woman also gets time to heal and also invest in nurturing and caring for the current baby who has been delivered. Absolutely. The other myth that I have interacted with communities and known, immediately after delivery, most women and most communities know that the only time you can engage again is after 6 weeks. Who said return to sexual activity must only be at 6 weeks?
Yes.
And that is where we get most families actually having problems after delivery, because the women in some communities believe that you can only engage after 6 weeks. But nowadays we are encouraging post-pregnancy contraception or family planning, so that immediately a lady has delivered, we are able to support them with a family planning in labor ward, so that they step down having been cared for well by a skilled personnel. They step down off the delivery bed with a healthy baby. They step down of that delivery coach loaded with a family planning method. And so for us again, mambo ni mangapi? Matatu. You are delivering under skilled care. You are having a healthy baby out of labor ward, and you are stepping out of labor ward loaded with a family planning method.
I like that. That. And it also removes the fear and anxiety that a family would have, right?
Exactly.
Even a woman, because I've seen this where a woman comes in and she's a bit shy of asking, right? Because of course there's either familial pressure. So then if you combine it, even as once you deliver, post-delivery, you can have a contraceptive method. It really helps, right?
You walk out of labor ward loaded.
Absolutely.
And so what does that do to us, Daktari? The woman is comfortable. The husband is comfortable, such that as they are walking out, they are sure at whatever point this lady will be comfortable to engage again. There are no stressors around her thoughts that I may again, if I engage, maybe get another pregnancy. But you're so sure that you are sorted.
Absolutely.
I think it's just important for the ladies who have given birth. We don't just give any type of
yes.
We give, if we are giving barrier method, we shall give either we advocate for CDs, right? For those who have undergone cesarean sections, we can give postpartum IUDs, but this IUD is progesterone only. Then for those who wish to have oral medication. We only give progesterone only medication. We don't give COCs. So it's good also for them to be aware that we don't give COCs because estrogen suppresses estrogen milk production.
Actually, it's a good point. You know what? Maybe we even need to discuss very briefly some of the side effects, right? Because I'll give you an example of myself, right? So in a committed relationship for a while, we're using condoms. Then it's time for me. I tried one of the combined oral contraceptive pills. But of course, given that it's hormonal based, then it had an impact on my body. I can't say it's a bad impact. It's just an impact that I can manage. But over time, I realized that maybe I don't want this, right? So then I had to go back and have a conversation. What is something that potentially I can't have the safe impact, but more importantly, I will not forget. Because then it became, okay, sometimes I'd forget and whatnot, right? And so then if it's a pill that you have to take every single day and I'll forget, that removes now pills, anything I'll take, right? And then I remember the second issue was that, okay, since it's hormonal, I have some side effects to the hormonal changes, right? So when the provider was suggesting, could you do, say, an implant, could you do this or that, as long as it was hormonal, I said to myself, maybe I don't want to do this, right? And also I was looking for something more long-term, right? So for the implant, it was a few months or so. And potentially the other thing was, if I wanted to have a child, I was thinking, okay, if in the course of next year I want to have a child, I'd want to have immediate return to fertility, So that's how I ended up settling on intrauterine device and the copper one in particular, right? So, but maybe give us a breakdown. I know in all that I've touched on here and there are some of the effects, right? Or side effects. What do you expect when you go, okay, barrier is more straightforward because it's a condom. It is, what do they call it? Is it a cervical cap? A cervical cap. Those are more insert, you remove, right? Then you go to pills, right? When you go to pills, there are different pills. What are the different pills, first of all?
So we have combined oral contraceptives and just monophasic contraceptives. Combined contain both estrogen and progesterone. And we have progesterone-only pills. Right? These are hormones. They have side effects. Right? So most clients will have headache. Not severe headache, manageable headache. Then because of the estrogen component, you might have water retention, giving you now, that feeling of you've gained weight. All right? Yes, and before we give this hormonal medication or any contraceptive, we have something called the MECWIL, minimal eligibility criteria. It's just an app, right? So the service provider will go through it, right, and give you the best method that you're eligible to use. All right? Yes. So most common side effects of this hormonal is basically just headache, tension headache, water retention, nausea sometimes, right? Then changes in mood, right? Then changes in libido as well. Changes in your menstrual cycle might be interfered for the first 3 months, but later on it will normalize. And then for implant, most importantly is that you might end up not being amenorrhoic for a year.
So you might not be able to
conceive
immediately.
Yes. So if someone wants to, get pregnant immediately, not to take so much time, we advocate something like IUD, what you're using, for return to fertility is immediately once it's removed.
I would just like to add that women respond differently to different methods.
Thank you. Yes.
And so if, for example, Robina would experience maybe spotting here and there, Dr. Diana might experience loss completely of bleeding, monthly bleeding. I'm making this be very simple so that our communities are also able to understand the language around the side effects that we experience during when we are using these methods. So loss or if you're using a hormonal method
Yes.
and you do not receive your periods, again, that is not a problem, because the hormones that inform bleeding every month for a woman is what they are taking.
Yes.
And so the contrary will happen. So our communities need to understand that the effects that we experience again vary from one lady to another. And that is why we need to counsel our people before they take up certain methods, so that as they are getting into utilization of contraception and FP methods, they are fully aware that if they miss their periods, it's not a problem, that it is tagged to the fact that they are using method XYZ. For example, the implants and DMPA, depot, how they know it. Again, the level of hormone, the amount of hormone in each method is good for us to know. I normally put it very simply. The longer the period, the lesser the hormone, the better the method.
Absolutely.
And so we always encourage communities to be able to take up the long-term methods, but at the time when they would want to get a baby, we simply withdraw the method from their system. So again, we really want to encourage our communities that contraception, giving yourself time to decide on when you want to get the next baby is the best decision anyone can make in their life. Because, for example, in this, most of our communities, our country recognizes an 18-year-old as an adult.
Yes.
If most of the ladies we are receiving in our health facilities are between age 15 and 24, who form the bulk of our communities. Now, if we receive a 20-year-old, for example, pregnant 20-year-old in our facility, where is this 20-year-old lady supposed to be?
In school.
They are supposed to be in school.
Yes.
And so if they are aware that they are engaging in unprotected sex and there is an opportunity for them to delay pregnancy, ain't that be the best thing you'd have done to this lady?
They'll finish school.
They will finish school, let alone those who are getting pregnant before 18 years.
Yes.
So that is the whole essence of contraception and family planning.
Absolutely. And I mean, it also addresses the misconception around it's a Western agenda, population control and whatnot. Because if you shift our mindset from it is an agenda of XYZ, and we say it's about us, it's about you and me, whether it's male, female. It's about being able to have control over your life, right? You want to be able to finish school. You want to get employed. You want, even if you're already employed, whether you're 30 or 40, you want it to be in a position whereby you can take care of a child, where the child is healthy as well. You want it that you, as the parents, the mother who's delivered and even the partner, you're mentally and psychologically prepared, because it's not an easy thing, right?
Exactly. And that again, Dr. addresses the myth around contraception being only for the married couple.
Yes.
We appreciate the value of marriage.
Yes.
I am a serious proponent of marriage.
Yes.
But our youth are engaging in unprotected sex.
You've said 15-year-olds.
Exactly.
I mean, you've seen in counties, there are counties where we know the incident rate, the prevalence for
Teenage pregnancy.
Teenage pregnancy.
50%. Where we come from, 50%.
Exactly.
That is very high.
It's very high, and sometimes you also imagine that it's not a secret. It's something that is known, right?
With evidence.
With evidence.
Backed by data.
Absolutely. Absolutely. And
Yes.
sometimes you even empathize with some of these communities because sometimes it's beyond their control, right? It's either where they're living, it's a social economic agenda. So you might not necessarily be able to change their immediate circumstance, but you want to give them tools that they can protect themselves, right? And that brings back even that conversation, and I think, Robina, you mentioned it, around ensuring that our service providers, it's not just doctors, right?
Yes.
Because when you go to the health dispensaries, health centers, it's not an OBGYN who's going to be there, right? That's why it's important to have you need to have them skilled, trained on a range, right? And I think Dr. Kechi mentioned the bias, because you'd never want to walk into a facility and they tell you that, the best thing for you is implant. Yet, they haven't had this counseling conversation with you. And they're leading you down the implant because maybe they know they do not have the skills.
The other option.
Or the other options as well, right? Because it becomes a right that if I walk in, I want to know whatever option I want, it should be there.
And I want to really appreciate the government of Kenya,
Yes.
Nairobi City County, and even the partners that we are working with,
Yes.
UNFP, MSK, Maristops. We are investing energies not only in facilities but also in the community.
Thank you.
Through the CHP,
Yes.
Community Health
Health
Strategy Model, Community Health Strategy Model.
Yes.
We have CHPs in our communities.
Yes.
MOH has an MNH module, technical module 10 and 11.
Yes.
Module 11 focuses on contraception, family planning. And this is tailor-made. The messages are packaged in a very simple language for the community health promoters to be able to understand. Remember, these community health promoters serve in the community.
Yes.
The communities tend to trust more the people they engage with frequently,
Yes.
the people they live with in the communities.
Yes.
And so by the choice of CHPs is derived from the community.
Yes.
They present to us the people they trust. And so when we leverage on them, when we train them, they are the ones who pop up these myths.
Yes.
And so it is in those classrooms, in those engagements, that we are able to demystify the myths that pop up within every community. And we empower the CHP to be able to engage one-on-one with the community members, the full range of ages, cohorts, to be able to address the myths as per the age groups and be able to support us break those myths down.
Absolutely.
So I would again want to request the communities to trust the CHPs.
Yes. The community health promoters.
The community health promoters.
Yes. Absolutely. And I mean, it leads very nicely into what was going to be my final question for Dr. Ketch in terms of just some of the strategies and innovative approaches you're using to combat some of these misconceptions, right? Because we've mentioned, yes, there's counseling, right? But are there other approaches that you're taking to say, first, yes, there is the awareness that people are aware these are their options, right? And I like what Robina said, that it's not just options, it's also an awareness around, if it happens, if this is the side effect I have, it doesn't necessarily mean it's the side effect Robina will have, right? Everyone reacts differently, right? But are there other strategies, other innovative ways that then, if this is the problem, this is how we're working on addressing it? Yeah.
So, well, we've collaborated with other partners
Yes.
that offer these family planning services.
Yes.
And we've leveraged on the community. We're able to pick our champions, people that we've been able to serve, and now they can talk to the community and tell them, this is what I used and these are the possible side effects.
Yes.
It makes sense when someone from the community tells you, other than foreigners coming to speak to you.
Yes.
So we've leveraged on the champions. Then we do outreach programs whereby we are able to, just have a sitting with the community together with, their husbands and kids, so that it becomes a shared initiative, not just for the women.
Yes.
Right. So then we're able to demystify these myths that they are having about around family planning. Then we've also engaged with religious leaders who are very, influential in the community. Right. So we are able to have a sitting with them. We hear their thoughts around family planning, and we educate them. Thereafter they are able to disseminate this information to the community. Right. Then one thing we've also strengthened and build capacity to healthcare workers through our various outreach programs. We train them on how to, to talk to various communities, so that we can break that myth around family planning.
Absolutely. And Robina, I'll finally end with you. Beyond, before you even give us a call to action, right? There's I say, as we started, right? It's about communities, their cultural, religious beliefs, right? So if we are to have these conversations, right? How do we encourage, right, more allies, right? What and perhaps that's the call to action. What do you typically say, so that people know, again, it's not a women's only conversation, it's not a married couple conversation. While there might be side effects, it's not one size fits all, that everyone will have a headache, it's not even the side effects that you may encounter. It might be for a short period of time. It might be something that's very manageable. I mean, we occasionally have headaches, not just because you're on a contraceptive method. Exactly. It's just because it's been a long day, right? You have a painkiller, or even sometimes you sleep, it's fine, right? There's an element of, it's a conversation you have with your healthcare provider or service provider, who then, based on what you need, if you want to get pregnant by the end of this year, maybe, there's one option versus the other. But then what would be a call to action, given all this, given the cultural, religious elements, right? What would be the call to action? Because a lot of the myths and misconceptions stem from those beliefs, right? Yeah.
The call for action is for us to take responsibility of our own health, and especially our reproductive health space.
Yes.
We need to take charge in that. If there are concerns that we have a whole system right from the community where we have access to CHPs. We are using a multi-professional approach where we are now allowing and engaging with community pharmacies to be able to open up the access space to for example, DMPA, Depo-Provera, both intramuscular and subcutaneous oral contraceptives are available in our pharmacies. Please let us engage. We also have the full range of health facilities, right from dispensaries. These methods are available. Let us get access to our health facilities, ranging from the dispensaries, health centers, up to the referral facilities. And basically, dispensaries, health centers, these facilities are there available for free. So there's absolutely, I would say, no reason why we would want to access services and there's a hindrance. The management team is available to address all concerns that are brought on board. And management ni nani? Management ni ule CHP. Wakipata there is a problem there, they are able to draw the attention of their link facility. Let us take responsibility of our reproductive health. The conversation of contraception again begins before pregnancy. Absolutely. And that is why we invest heavily, especially in the antenatal space, where we throw a challenge to the pregnant women. When do you want to get another pregnancy? While you are still pregnant.
Yes.
So it already sparks your thought around, anyway, I am carrying this pregnancy. How much time do I need for the next pregnancy?
Yes.
And that will guide us through deciding which method to go for. If we want to get pregnant again after 3 years, I'll definitely go for the implant that is 3 years. If I want to get pregnant again after 5 years, we have options which are available for 5 years.
Absolutely.
So taking charge of our reproductive health space and calling upon the men to support this conversation.
You're representing an entire agenda
The
now.
men. Calling upon the men to support the women in making decisions that will inform our reproductive health.
We're taking charge. Robina.
Taking charge.
Taking charge.
Yes.
And support is required. I mean, thank you so much, Dr. Okech, for coming. Robina. Robina, you have to bring us some users, people from the community. We have a conversation at least.
I'll make it
A
my
point.
duty.
Absolutely. And you come with them as well.
I will. Yes, you can be sure. That I commit to.
Absolutely.
Yes.
Thank you so much, Asante.
You're
This is a
welcome.
conversation we need to keep on having.
Yes.
It is not about someone else's agenda. It is about us taking charge of our lives.
Yes.
I really liked that.
Karibu sana.
Thank you so much for joining us on the One Health Lens podcast. We'll continue having these conversations around contraceptives and family planning in Kenya.